workers. If we go in for THA after fracture neck femur in this gray zone, there is less disability, fewer days out of work, and lower indemnity cost than those who were fixed. So just one patient who in my practice who came late after maybe 4 months. So there was no need to fix such fractures. We can directly replace them. So now coming on to the young patients with very unusual indications like fracture neck femur associated with acetabular fractures, rheumatoid, polio, cerebral palsy, hip dislocation, and osteoarthritis. I'll share a few case examples like one patient with polio around 50 years age, osteoporotic, no need for fixing them irrespective of the age. And then another patient with hemiparesis, again, osteoporosis associated. So they were replaced with dual mobility cup. This is our own patient, which we published in 2021. Fracture neck femur, fracture acetabulum, dislocation head. So we did open reduction and primary THR after the fixation of the acetabulum, non-cemented situation, and he went on to heal very well. And then we scrutinized the literature. The patients who underwent direct arthroplasty after these complicated fractures, they did well, all of them. And the people who were fixed primarily, they went on to have AVN, arthritis, non-unions, and they had to be replaced ultimately. Few more case examples of these young patients: fracture neck femur, dislocation, and polytrauma patient. And after everything healed, we could attend to his hip, a short stem, non-cemented solution. Another patient, polytrauma, neglected fracture neck femur with dislocation, fracture acetabulum. And after all the fixations, we did a primary arthroplasty. So to summarize, friends, if you have elderly patient with non-displaced fracture, fixation should only be done when appropriate, otherwise do arthroplasty. And then in elderly patients with displaced fractures, arthroplasty has superior outcomes and dual mobility should be preferred. Consider hemi in an elderly patient with low demand beyond 80 years, and in the gray zone patients, try to preserve, but it's not a sin to replace. You have to select a proper patient for preservation and a proper patient for replacing. And these unusual indication, primary arthroplasty is better. Thanks a lot.
Thanks, Dr. Avtar, for a lucid talk on a very difficult subject, fixation versus arthroplasty, and you try to give the right explanation for each of the situation. Thanks so much. May I request you to unshare your screen so that Dr.
Sure.
Kukuh can share his screen. And now I'll invite Dr. Kukuh Dwiputra to speak on indications for arthroplasty and take the discussion further ahead. Dr. Kukuh, please.
Thank you, everyone. Hi, good afternoon, good evening. First of all, thanks, Rami and Raji, for organizing and inviting this wonderful event. It's a good start to collaborate and encourage the young surgeons for such interesting topics. So my topic will be the indications and evidence and also considerations for the arthroplasty for femoral neck fractures. My presentation will be quite straightforward, and I will add some with what the Avtar have. Hi, good afternoon, good evening. First of all, thanks, Rami and Raji, for organizing. As explained, I will not go further for introductions. That we know that the burden of the femoral neck fracture is increasing every year and is expected to reach more than 5 million by the 2050. And it's an indicator of care, whether it's good or not for geriatric populations. And it is one of the 10 most cause of the high mortality and disability in geriatric patients. And also from the socioeconomic and finance perspective, this is a contributor for the global economic health crisis. And yes, it has a poor healing capacity and high rate of displacements, and with 20% usually not displaced, but 80%, most of them are displaced fractures. So the issues here is whether to treat conservatively, is there still a place for conservative? Or if we do surgery, when is the best time to do the surgery? Whether to fix or to replace, Avtar has already explained very well. And last, the never-ending debate whether to partially replace or totally replace. Okay, when we decide whether is there still a place for conservative treatment, yes, we reserve these options for patients with significant pre-existing comorbidities, with minimal baseline ambulations, and we don't expect the patients to have very good outcomes. But because we know that conservative treatment in femoral neck fracture has worse mobility scores, pain, and mortality, and there's a high rate of displacements, up to 50% with chance of neck osteonecrosis within 2 to 3 years. But one interesting study in 2019 shows that for patients geriatric 65 years old, but garden type 1 shows that treated conservatively, 2/3 of them shows that conservative treatments could be effective. They showed the patient were happy and satisfied with the conservative treatments. But please bear in mind that there is still risk for displacement, especially when there's a dementia, repeated falls, or comorbidities more than 2 or 3. Therefore, now the trend is getting to the surgery, because we know with surgery, the goal is to mobilize and to return the functions of the patients. But still, whether to fix it or partially replace or totally replace, all of them, the most important factors to consider is first the fracture patterns, the age of the patients, the patient functional and mental status, also the comorbidities. If we decide to do the surgery, when is the best time to operate? Yes, the clock is ticking. Delay is not advisable. Recommendations of various national societies, from the Canadian, the Australian, British, the US, the European, says that it is a very urgent surgery, should be done on the day or the day after, within 48 hours, unless there is an identified comorbidities that we have to deal with. It's a very good meta-analysis, although it's quite in 2008 with more than 200,000 cases, that the delay of more than 48 hours will increase the 30-day and 1-year mortality rate by 41 and 32%. So it is better to get the patients treated surgically as soon as possible, not more than 2 days. Okay, now to fix or to replace, I will not go further because Avtar already did very well. But what I want to emphasize here is over 12 years, more than 200,000 cases, the fixations is declining, and more surgeons and more literatures have come up with the idea of arthroplasty to be more beneficial, as soon as possible, not more than 2 days for internal fixations. Okay, now to fix or to replace, I will not go be young and active patients with non-displaced, and if there's infections, fungus infection is more favorable. And we have to bear in mind that the reoperation rate is 4 times higher than the arthroplasty. So worse functional outcomes, higher failure. At first, maybe the cost of the implants for arthroplasty might be higher than the internal fixation, but there is no evidence that internal fixation is more cost-effective due to the reoperation rates. So, whether to fix or replace, as Avtar already said, and I agree, that depends on the patient's characteristic. Now, it comes with a hot to never-ending debate whether to partially replace or totally replace, because despite the advantage of the arthroplasty, the choice between hemi or total is still controversial. Yes, we agree. Patients with low functional demands and poor cognitive functions with significant morbidities with limited life expectancy should be done with hemiarthroplasty. But if there's a pre-existing acetabular wear, total hip arthroplasty should be preferred. We can see here that if the patient is we expected to perform better, active, or maybe a good longer life expectancy, total hip is the options. But sometimes it's not as easy as that to just decide. That's why the Swedish group, they have come up with some score. This is actually a very applicable and practical score. The Sandberg score, it consists of 4 components: the age, where the patients live, how the patient perform or walking before preoperatively, and also the mental status. If the score is 515 or more, that means the patient should do well. So the total hip is a choice. But if less than 15, hemiarthroplasty can be considered. If we go through all the literature, hemi versus total is never ending. And there's various studies, even the RCTs or meta or everything. But I will highlight some points that those who favor total hips shows that in 25 months follow-up, the functional outcome, the quality of life are better. And then also longer follow-up to 3 years also show better with good SF36 mental subscale and superior WOMAC. But again, one of the drawback of the total hip arthroplasty, remember that there's a greater dislocation rates in the first 4 years. But after the first 4 years, there's no significant difference. On the other side of the coin, you can see that there are studies that shows that there is no difference between hemi or total. A study in 2019 by the Kumar says that for octogenitarian patients more than 80 years old, there is no difference in terms of hip function, quality of life. And this shows that maybe if the patient is more than 80, then hemiarthroplasty is not a problem. Another study also showed multi-center say that they have similar mortality rate, equivalent results for pain, stiffness, and functions. And another RCT shows that there is no difference in the functional score, revision rate, or mortality rate. So again, there is no black and white here. Hemi versus total should be tailored to each patient. Not only the patterns, but we have to take very deep considerations to the baseline morbidity of the patients, the activity level, the physiological and mental reserve of the patients, and also the comorbidities. To make it easier, a lot of algorithms have been published in several literatures, like as old as in 2002 in Core. We can see that the trend that time, the cutoff point was 70 years old. Yeah, whether which is displaced or not, whether to put a certain fixations or not. But now, as the implants technology evolve and all those life expectancy changes, now the newer one, the 2014 algorithm, or even newer 2018, they have the cutoff points at age like 55 or something. But again, this algorithm can serve as guide for us to help to decide, but it's not the black or white situation where we can choose right or wrong. So to summarize this topic, femoral neck fracture is increasing and is associated with high risk of morbidity and mortality. We need more evidence, but the current evidence support arthroplasty is preferable in displaced femoral neck fracture. However, hemi-total remain uncertain, but the best treatments should be tailored to each patient's individual health to select the optimal treatment method. Thank you, and please join us next month in Cebu. We will have a lot of fun there, a lot of big names with faculty, and we will have a lot of good time there. Thank you very much.
Thank you, Kukuh. I think it was a wonderful explanation, and we'll be taking it ahead with the surgical approaches being explained by Saul Qurashi. Saul, can you please share your screen? And Rami will be having the discussion after this Saul's talk for about 10 minutes. Yeah.
Okay. Thank you, Rajiv. I'd like to start by thanking the organising committee, Rajiv, and thank you, Rami, for the kind invitation to speak tonight. My name is Qurashi. I'm from Sydney, Australia, from the Penn Hospital, and I've been tasked to talk about approaches associated with total hip replacements, specifically in relation to neck and femur fractures. And now we heard some really good talks, some demographic data, and the fact that the trend to total hip replacement, also to trend to neck and femur fractures, the incidence prevalence is increasing, and the trend towards total hip replacement has also been increasing. So I'm sorry I don't have nice videos or anything exciting slides, but most of my slides are data, but hopefully we'll find something useful. So this is a graph from the Australian Joint Replacement Registry showing the trend over the last 4 or 5 years, and it's slowly going up. Nothing exciting over there. But when you look at the registry, fortunately, our registry is fairly comprehensive, and we have almost 25,000 primary total conventional hip replacement procedures registered for a fractured neck and femur. When you look at the results of these at 15 years, it's got a cumulative revision rate of 9.4%. When you look at that figure, it doesn't really look that bad. But I think this is a bit of an illusion because, sadly, when you look at the survivorship, and I'm not talking about the implant, I'm talking about the patient themselves, unfortunately, 70% of these people are not with us at 15 years. When you look at the revision rates for total hip replacement, probably the most common reason, common subgroup is the one where neck and femur was the primary diagnosis at the time of the index procedure. You might wonder what this has to do with the approach, but I'll get to that shortly. When you look at the incidence of revision and the cause for revision in a total conventional primary hip replacement with the diagnosis of fractured neck and femur, the things that stand out are prosthesis dislocations. The instability as being the primary reason for dislocation, followed by fracture and then infection. When you subdivide this and look at the comorbidities of the patients by ASA, so ASA 1 to 4, in ASA 4, you can see a much higher revision rate compared to the ASA 3s and 2s and 1s. And that's understandable and predictable. When you subdivide it and look at it, ASA 1, 2, 3, 4 as the cause for revision, you'll see that in the ASA 1, fracture is the most common reason for revision. And as the ASA score goes higher and higher, the dislocation and instability emerges as being the primary cause. And then when you get to ASA 4, infection being the primary cause. So instability and infection then emerge as being the main causes of revision. Similarly, when you look at BMI, the joint registry divides up BMI as underweight, normal, pre-obese, which is overweight, or used to be overweight in the old classification, and then obese after a BMI of 30, which is then further subclassified into 1, 2, 3, based on how obese they are. So when you look at the morbidly obese, BMI over 40, and we have more than our fair share of those individuals in Australia, particularly in the location where Rami and myself and Min-Jae work, the revision rates are almost 5 times as high as the normal weight and the underweight. And again, when you subclassify these, when you look at the morbidly obese, the class 2 and 3, you can see the infection and instability as being the primary cause, but infection becoming the main cause. Now, I don't know what that has to do with approaches, but one wonders. And the approaches to do a total conventional primary hip replacement are the same for neck and femur or for osteoarthritis. The ones that I'm familiar with are the direct lateral approach or the hard-hinge approach, the conventional posterior approach, which is probably the most prevalent, the direct anterior approach, which I personally not have much experience with at all, but it's a commonly used approach for neck and femur fractures as well. And of course, SuperPart, which I've had a fair bit of experience with over the last 10 years or so, and I've used them for neck and femur fractures as well. But admittedly, I've only done a handful of neck and femur fractures with it only because of the sort of patients that I see, mainly elective. And when we're on for trauma, often you might not have the sets available, etc. So looking at the data, unfortunately, there's not really much data about outcomes of total hip replacements for neck and femur fractures, specifically in relation to approach. It was actually quite a hard task to find some of the studies that were meaningful. But I start with one of the biggest studies, and this is from the British Registry. It was published about 3 years ago, and they looked at 14,000 patients, 7,000 in each group, and they compared posterior versus anterolateral approach. And of course, this debate, posterior versus anterolateral, has been going on since the last century, and they collected data over a period of 15 years. And what they found was that intraoperative complications were slightly better in the posterior approach group. 30-day mortality was also better or lower in the posterior approach group, and that trend continued at 1 and 5 years. But the 5-year revision rates were pretty similar in both groups. Admittedly, they were all small differences as well. So they were a bit timid in their conclusion, which basically just repeated their findings and said, look, posterior approach slightly better, but really they're both very similar. Then the Scandinavians did a study with almost 5% of the numbers of the cohort, admittedly prospective study. And they looked at dislocation as an endpoint for total hip replacement done for neck and femur fractures in relation to approach. So again, they compared, looked at 713 patients, again, over a 10-year period. They compared anterolateral approach and posterior approach with or without capsular repair. And their overall dislocation rate was 6%. It was 2% in the anterolateral group and 12 and nearly 14% in the posterior group, depending on whether the capsule was repaired or not. And they were not so timid in their conclusion. They basically said anterolateral was better. Then a study even half the size of the previous one, again looking at dislocations. And I wasn't really sure if I should have included this, but it came up. This was a South African study looking at direct lateral approach versus others. And they found that the dislocation rate in the direct lateral approach was quite high. They had almost a 4% dislocation rate. Having said that, it was a flawed exercise because, that's right, because 93% of their patients were direct lateral approach, and it was only about 7% anterior and less than 1% posterior, and all the dislocation happened in the hidings. So it was a bit of a skewed comparison. I am biased about SuperPath because that's what I do. So I wasn't expecting to find anything. There was a few little studies more to do with other diagnoses rather than fractured neck and femur, but I came across a meta-analysis. I was surprised. And this meta-analysis looked at 9 studies. Again, when you look at the quality of the studies, they're quite small, and the conclusions weren't really that clear-cut. But they repeated the findings that is out there in the literature in favor of SuperPath for other diagnoses, not just fractured neck and femur. So, early mobilization, quicker functional recovery, and some improved surgical outcomes and short-term functional outcomes, which we all know about. Now, direct anterior approach, that's really taken off in the last 15 years. What about them? So this is a study from 2 years ago. And again, a small study, 143 patients, 99 of them were posterior and 44 of them were direct anterior approach. And they compared the two groups. And they found that, the perioperative complication profile was very similar, except for the 1-year mortality rates were possibly better in DAA. And they came to the conclusion that this maybe a DA might be a predictor of long-term mortality in fractured neck and femur fractures. Respectively, I'd have to disagree with that because your study sample is less than half, and there's so many other factors. But we thought, okay, well, let's stop looking at studies. Let's look at something more substantial, non-biased. And as Australians, we're very proud of our Australian Joint Replacement Registry. So what does that have to say? And fortunately, since 2015, the Joint Registry has been collecting data on approaches as well. And since 2015, we've had 62,000 direct anterior approaches registered, 34,000 lateral, and more than twice the number of DAAs, 122,000 posterior approaches registered. And this is not for neck and femur, this is just for all diagnoses, mainly osteoarthritis. And it has found, based on approach, no difference in the overall rate of revision when surgical approach is compared. However, there were types of, in the types of revision, there were some differences. Specifically in relation to DAA, there's a higher rate of major revisions with direct anterior approach compared to other approaches. That's what that looked like, the green line. And the main reasons for revision in direct anterior approach for neck of femur were loosening, fracture, infection, dislocation, in that order. There was a higher rate of revision for loosening with anterior approach compared to both posterior and lateral approaches. That's what that looked like. There was a higher risk of rate of revision for fracture with direct anterior approach as well. But that was mainly in the first 3 months, and after that, that difference sort of pretty much dwindled away and became similar with the other approaches, and that's what that looked like. On the positive side, there was a lower rate of revision for infection with anterior approach compared with both posterior as well as lateral approaches. And there was also a lower risk of revision for dislocation and instability in the direct anterior approach compared to the other approaches, and that's what that looked like. The green line was much lower in these graphs. But again, is that an illusion too? Because what the registry also states is that the anterior approach was done more often in younger patients and more often in patients with a lower BMI and a lower ASS score. So then when you look at this graph, if you take this one out, this one out, this one out, you don't really have to worry about infection. If you take this one, and this one out, you don't really have to worry about infection and dislocation. So I think there's a significant bias, a selection bias in those positive findings in favor of direct anterior approach there. So unfortunately, there's not much more to find. And from that reading, I concluded that really, there's no best approach. You just have to do whatever works best in your hands, because as long as it's done well, it'll have as good as a result as can be. But it's worth noting that it's not just the approach. And as Dr. Avtar and Dr. Kukuh pointed out, there's so many other variables, particularly with neck of femur fractures. And again, another graph from the Joint Registry, which shows that bipolars are still performing better than total hip replacements for neck of femur fracture at pretty much all levels, from 0 years all the way to 19, 20 years. Okay, you have to be selective. So for that younger patient, the gray zone or the more active one, or the 60-year-old who's really fit, fell off the back of the truck, or in those patients, you do see that primary total hip replacements do better from the index time to almost the 13, 14-year mark, and after that, the differences are a bit variable. But when you look at the elderly over 70, bipolar performs better pretty much all along. So, and then you throw in, dual mobility, you throw in head size and all these other things. So I think there's a lot of other things other than approach that are worth thinking about when you offer arthroplasty to these patients, because the data, even though we're always worried about hemiarthroplasty and acetabular erosion, etc., but the Joint Registry is actually very much in favor, especially in the elderly, for hemiarthroplasty. And remember, the survivorship in these patient subgroup is fairly low at 15 years. 70% are not there anymore. So you want to give them one operation that will hopefully last them a lifetime and take away their pain and fix the problem they came with. I hope that was helpful. Thank you.
Thank you, Saul. That's very good explanation. Yeah.
I'm just trying to find my stop sharing button. It's disappeared.
It's unshared now. Thank you so much. Yeah. So Rami will have a short discussion on the 3 topics that we have just had. If I may ask to begin with, Saul, what's your, if you have to fix a fracture neck of the femur in a, say, person of 60 or 70, what is the timing for the surgery that is preferred in your part of the world? Then I'll ask the same thing with my Indian colleagues also.
I think if I'm fixing it, then as Kukuh said, time is of the essence. You want to get onto it within the first 24 to 48 hours. And obviously there's limitations with the hospital system and bed blocks and this and that. But at Nepean Hospital, we have a NOF pathway. So the aim is to streamline this as quickly as possible. Fortunately, we have trauma theatres available every day, and the NOF patients are prioritized. There's always obstructions from anesthetics and this and that, but usually the aim is to get them done ASAP.
So do you do it like on the same night or within, say, a few hours in some cases?
No, the next available list. So if something comes in the morning, we'll try to get it
yeah.
done the same day. If something comes in the afternoon or evening, the next morning.
Yeah. Devan, the same question for you. I mean, do you do these cases in a first 3 or 4 hours? Deva, you're still on mute mode.
Okay, actually, it is well established that these fractures, if we want to fix, then we have to do as early as possible. But as you know, this gray zone area where from 45 to 60 years, 65 years, where we decide on the chronology of the patient and decide whether to fix or not to fix. Those cases, actually, if you want to fix them, you have to do it on the first available list. Because overnight, if you do in emergency, in these cases may end up with some medical problems because there will be associated.
So your take is that on the first available list, as Saul has just explained. Vivek, you are the head. Yes, Saul, please. Saul, you had some statement. Yeah.
Add to that. So this is for the 60, 70, 80-year-old. If you have a 30, 40-year-old, would want to do that ASAP. We'll probably want to aspirate the capsule as well, get rid of the hematoma and fix that. But fortunately, that situation is very, very uncommon.
Right. Vivek, you are heading the unit in one of the biggest center in India. Vivek, what is your take on this? And then I'll come to Uttam.
Okay, thank you. I feel that it is the same as Dr. Qurashi told, that if it is a young patient and our main and primary the evidence shows that the young patient is going to have a good outcome with neck femur fractures, they will be operated as early as possible within the first 6 hours to 8 hours. All the machinery of the trauma center is going to be rolled up for him like a fast pathway, just like we do for intertrochanteric fractures for the elderly. The same way it is going to be done. For elderly above 50, 60 in Indian population, the next possible best list at routine time, which will be, if the day comes, if he comes in the morning, by evening, otherwise next day morning is the thing. But remember that it's only the undisplaced fractures in the elderly that we are managing by salvage of fixation. As was shown by the various speakers till now, the evidence shows something different for the displaced neck femurs in elderly.
And Vivek, one short comment on whether do you aspirate these joints before you fix, or you just fix the joint, the fracture?
No, in adults, we are not doing the aspiration, as I say. In children, yes, there is a proven evidence that if you do that, the tamponade effect will reduce and the vascularity can be maintained. Not so much in the elderly population or in the young adult population, so as to say.
Right. Uttam, you had some comment.
I totally agree with Dr. Vivek that in a younger patient, the 40 to 45 year, where we have a good chances to the union, I will prefer to get it operated within 6 hours as early as possible. That's my take.
Dr. Ajith, what is your take on this?
Yeah, so I work in a private setup. So it's a slightly different. The thing is, there will be just 2 or 3 trained people, in the sense fracture reduction is of utmost importance if it's the gray area that we're talking about. So to assess that, you cannot leave it to the registrar, I would say. I think it needs experience. It needs perfect reduction. So in such cases, we wouldn't mind waiting till the next morning. Okay. In the elderly, yes, it's the next available list.
Right. Kukuh, the next thing is that do you have anything new in fixation of the fracture neck of the femur? Or you just go with the 3 screw fixations parallel to each other? Or you make them one of the long screw, which is buttressing the fracture?
Okay, this is very interesting. A lot of my residents also keep on asking the same question, whether 3 screws are
right?
three screws are mandatory. Because if we see that from the evidence, the 3 screws are biomechanically more stable, they are better to withhold the stress. But we remember for Asians, know that the neck is shorter and is smaller. And we've tried to squish in 3 screws, and most of the cases we cannot get through it for the Indonesian population. So most of the time we put 2 screws. Yeah, and well, but another thing is not about the screw, but another thing I have always emphasized my resident is how could you reduce the fractures, because even though you have put 3 screws, but you don't make a good reductions, then there is a high chance of collapse of the fixations. Yeah.
Very right. Specifically, if you have a posterior comminution, it's a major issue, and one has to, as you rightly mentioned in your talk, that posterior comminution should be seen well, documented well in the lateral screw, lateral view of the X-rays. Yeah, right. Min-Jae, do you have any comment about any newer fixation type or newer fixation way?
In Australia, we've moved largely away from using DHS and using intramedullary fixation devices such as a gamma narrow or a PFN or into 10. Mainly reason being where the training-wise, we've been more exposed to intramedullary devices compared to a DHS. We've certainly used DHSs and cannulated screws in subcapital fractures, base cervical fractures, but certainly for intertrochanteric fractures with subtrochanteric extension and more complex types, we'll certainly use intramedullary nails for fixation. In terms of timing, certainly for young people, we'd like to take it early as possible. The 6-hour rule is a traditional rule that's been taught to us by our elders for a long time. But I think reality, in Australia, we try to take it in as early as next available list as possible.
Right. Any comment about the aspirating the joint before fixing?
Most of the time, the capsule is disturbed in these kind of fractures. So once you try to reduce it, and often requires open reduction as well. So if you do an open reduction, it's already open. But certainly, if it's a closed injury, well, if you can reduce it closed, then I wouldn't aspirate as a routine in my practice.
Rami, your final statement on the aspiration, whether our young surgeons should do it or not, and the type of fixation.
Yeah, look, I agree with Min-Jae. We don't aspirate as a routine, and fixation has gone to gamma nail style or intramedullary fixation and 3-screw fixation. Our femoral necks are a bit broader than those in Indonesia, and 3 screws are very easily placed and provide sufficient fixation. But what's been interesting, Ajith, I see you there. We'll ask you to comment next. What is interesting, though, is that, all 3 presenters have given an excellent presentation on how the trends have changed over the last 10 to 15 years. And they've changed away from internal fixation in those over the age of 65 with displaced fractures. And what would be good, and what I want you to think about for the next Q&A session after the next 3 presentations, is we're going to make you all a bit older, each member of the panel. You're going to be 65 and over. You're still functioning as an orthopedic surgeon. You've tripped over playing tennis and you've fractured your neck of femur, subcapital, and it's displaced. What I want to know is, what would you choose as the implant of choice to have yourself, and what approach? That's what we want to talk about at the next Q&A session. Ajith, I know you've had your hand up there. Your comments.
Yeah.
No, I just wanted to get an idea about, you talked about the nail for the fractured necks. Now, there is a slight variation or a problem with the vertical shear fractures, the Powell type 3s.
Hello.
Sorry. So would you still use the same thing, or would you make some...
Ajith, you're on the mute, please.
Sorry. What I meant was the Powell type 3. Would you still use an intramedullary device, or would you do something slightly different there for the, because I've not heard or not read too much about intramedullary devices as yet. So I'm just curious to know, at least in the type 3s, would there be a variation in your strategy?
Min-Jae, you want to comment on that?
Yeah, so for subcapital fractures, Power 3 you certainly try to use a DHS, so it's a cannula screw. It's difficult to control rotation with the intramedullary canal in the femur, because you can't. When you put the lag screw in, you've only got really a bit of room in the anterior to the neck to put a wire in to control rotation. So in that case, my certainly preference would be to use a cannula screw or a DHS with a derotation screw to control rotation as well as control rotation.
Thank you.
But in that specific situation too, Min-Jae, where you've got a more vertical fracture line, do you do anything different?
It depends on the age group of the patient. Obviously, if it's a young patient, you try to err towards fixation. However, if it's a sort of borderline, I don't want to name ages, but about 45, 50-year-olds, my preference will be to just do arthroplasty. I think they are predictable. The long-term longevity of these implants these days are very good. And even if you do arthroplasty in 45, 50-year-olds, the longevity should be 15, 20 years according to the latest data. So if it's that age group, then I'll be more tentative to do arthroplasty and then primary fixation. But if it's a much younger patient and a multi-trauma, such as a 20-year-old or even younger, then certainly fixation will be the way to go.
Right. And just finally, Dr. Avtar, you demonstrated a very good case of a vertical fracture that went on to a delayed union. You did a subtrochanteric osteotomy with a very elegant union of the osteotomy site. But despite that good effort, you still had osteonecrosis. So that's still a problem and a complication. Okay.
Dr. Avtar, your comment about your...
can he come again? I just missed it.
I was just saying you gave a very good demonstration of where in a delayed union or non-union in a vertical type fracture PAL3, you did a subtrochanteric valgizing osteotomy, and it was a very elegant procedure that led to a nice union. But despite that, there's still an incidence of osteonecrosis that you ran into as you demonstrated. I thought you might want to comment on that.
You see, when I searched the literature, surprisingly large number of them. One series showed 13 patients out of 58 who were having osteonecrosis shown on MRI, which is not seen on X-rays actually. So maybe he fits into that category. And when he came back to me, it was all collapsed and gone. So I had to convert that into. So we need to observe these patients over a longer period of time till they are fully cured. Probably at least 1 year or maybe more than that. We need to follow them up actually.
That's very right, that in spite of the good fixation and success in union, you still have a problem of avascular necrosis. And following them up is a very important point. Thank you so much. Rakesh, you had a comment on this?
Yeah, I'm not really comment. I have also noticed the same thing as what Dr. Avtar has said, that these patients and we've also done a lot of valgizing osteotomies, even for younger patients who've got power 3 fractures. That's our go-to operation actually for younger patients, without hesitation. But what Dr. Avtar has noticed of going into AVN, we have also noticed that, and these patients will continue to complain of pain in spite of looking good healing both of the osteotomy and of the actual fracture in femur, and still they have pain. And then these patients are heading towards an AVN. That's a very good symptom to go through. And sometimes they start getting not much pain, but limitation of hip movements. And that's again one case which will go on to AVN. So my question actually was to Dr. Saul. He presented very good ideas about, fracture neck femurs, THR and different approaches. So I just want to ask him that we haven't covered the approaches for if they are heading towards an hemiarthroplasty. Let's say because these are more elderly population doing hemiarthroplasty. Does there an approach makes a difference?
Thank you, Dr. Rakesh. To be honest, I don't know. I haven't come across, I didn't really look for any literature. I was doing a literature review specifically for THRs. What I do know is that, you've got a much bigger head. I guess dislocation is probably not likely to be as big a problem as in a primary THR for a neck and femur fracture. My preference, for example, if I have to do hemiarthroplasty and we don't have and that's what I'm doing, that I'll use a posterior approach with a piriform preserving, like a mini posterior sort of a thing. I'll use a cemented construct, so then I can dial up my version according to my trials. But I'm not sure of any approach-related advantage or disadvantage, specifically in hemiarthroplasty. So traditionally, we were always taught to do the direct lateral approach in Australia for hemiarthroplasties. It's an operation primarily done by the trainees. But as a consultant, I've done as a posterior approach, but I guess there's no right or wrong, as long as they can do it well, or whatever they feel most comfortable with.
Can we have a show of hands amongst the faculty and the panel? How many of us are using the, for the bipolar processes, for example, the lateral approach or the Harding's approach? And how many will go for the posterior approach? Okay, so that's a good explanation, almost equal on both sides. Yeah. So before we go to the next talk by Dr. Rakesh Rajput, may I just ask one quick comment from the faculty about the, you mentioned the dual mobility, and Dr. Avtar mentioned that majority of his surgeries are with the dual mobility cup now. So how many of us are using the dual mobility as a routine for total hip arthroplasty in fracture neck of the femur? Just a show of hands, maybe, or maybe a quick comment from one.
I'll make one comment I want to make.
Yeah, sure.
And it's just a comment about the approaches. We are talking a lot about the approaches, the posterolateral, anterior, or the lateral. But now, if we are bothered about the dislocation, and now we know that the dislocation rate is the minimum, the least with dual mobility. So to my mind, approach doesn't matter at all. Whatever approach you are good at, you must follow that and use the dual mobility without any fear of dislocation.
So just a comment about our younger surgeons for their benefit, that fracture neck femur is mostly having the normal capsule. It is not a contracted capsule because of the years of arthritic process. So here the dislocation rate remains high, and that's how the question is whether to use a conventional total hip articulation or a dual mobility. So we'll be discussing it more after the next three talks. So may I now request Dr. Rakesh Rajput to speak about the cemented stem and the scenario of cemented stem and fracture neck of the femur.
So, Rajiv, am I visible and audible?
Yes, very much.
Yeah, I think thanks, EOPAS, for giving me the opportunity to talk on this subject, which actually is very close to my heart. So it's cemented stems in fracture neck of femur. So I think it would be not right to speak about cemented stems unless we pay homage to John Charnley. I never had an opportunity to meet him because unfortunately he had passed away before I went to England. But I did meet the next best person who was training with him and in Wrightington, Dr. Obreski. And I think Bodo Padak has managed to continue the same legacy. We say that we want to shift to uncemented stems because our patients are getting very active. And these are sort of all activities we say in favor of trying to put uncemented stems. So what my brief would be to actually look at the indications for fracture neck femur, where I think the cemented stems would come into picture, and some design issues as to why cemented stems probably would be preferable, their biomechanics, their insertional issues, rehabilitation cost, and in case you end up revising them, how easy is it to revise a cemented or uncemented stems? So I think introduction, first of all, to know that cement itself is not a glue, but it is something in which the actual stem is going to go in. It has two intersurfaces. One would be the cement and the bone, and the other would be the bone and the actual, the cement and the implant. So we'll go into this two designs because there are two different ones which you want to use for in cases of, fracture neck femur scenario particularly. So you should know about how these two work, and practical considerations will be required. Number one, when you have a neck femur fracture, you haven't, made the neck cut. So it is beyond your control. So you have to just go ahead with whatever neck femur cut you have. It may be high up and you can revise to make it what you would normally do for a THR. But in many cases, it will be so low that your uncemented stem may be sort of jeopardized and may not get that hold. So here, the cemented questions are not of an issue. So if you are going for a cemented, you can keep it down, you can keep it up, you can get your length right based on that because you're not based on your reaming issues. The other stems which are more like Charlie type stems, composite ream, the reason I'm saying is that because sometimes the shapes are different and you may not get enough filling in these patients. Now let's look at the morbidity and mortality issue, because this is something what is being proclaimed in different literatures as to something against the cemented stems. And the incidents which we quote every time about is the bone cement implantation syndrome. And I've seen a lot of American literatures actually highlighting this issue and going in favor of a uncemented stem. That we know what the reasons for this. We won't argue into reasons, but this is something one needs to be aware. However, we have got very knowledgeable about this. We have been warning our anesthetists when we put in cemented stems to be in the OT at that time and not going somewhere out for having coffee, and be aware of the blood pressure, be aware of the hydration, and be aware of the oxygen level. And we really hardly see any more of this bone cement implantation syndrome. Not that I saw it a lot even in the before when we were not aware of it, but now that we are aware of it, we're actually a bit more conscious about it. But look at all the other advantages you get with cement in fracture neck femur scenario particularly. One, you definitely have, and all the literature before which has been quoted before me, highlight that overall mortality with a cemented cemented stems are less, and you definitely get improved function, because many times with an uncemented stem, you're not really sure that you have got enough fixation, particularly in this elderly osteoporotic bones. But with cemented stems, no such issue. You can immediately go and start functioning with the next day itself. And definitely that, because you're not really going for a jam fit, you definitely will have a lower risk of a periprosthetic fracture, and you will have a very good and reliable fixation, and perhaps in long term less pain with this. Now look at these all three femurs, all these three, and the way of inserting, not an issue with the cemented stem. Now if you look at the different indications, even for neck femur fractures, and many times we quote this age 70 as a magical figure. I can tell you that our Asian populations, particularly in my subcontinent India, which is 1.3 billion people, 65 would be as same as 75 in other European countries. So our patients are actually more osteoporotic and more elderly at a much younger age. And whichever femur doesn't matter, even if your neck femur has got rheumatoid, badges, osteoporosis, not an issue. So the indications for like any type of stem, you can go ahead and put a cemented stem. Any type of fracture neck femurs, you can go and put this, whatever conditions you have. And we have a saying in India that, what more do you want? And we always say, dil mange more, means my heart desires more. So we want something more with these issues. Now let's come at design issues. We know uncemented stems, every year you see a new stem which has come into market and you got to get used to it. Uncemented stems has almost remained same over a long period of time. Then there comes question about stress shielding. I know this has also been taken care of a lot with these stems we see, but still it's an issue, and we need to slightly worry about it. We still see breakage of these stems when put it even for neck femur fractures. Now let's look at biomechanics. Particularly as you grow bigger and bigger, you need to put larger and larger stems. And what happens? These patients, either you will not be able to put it, or once you manage to put it, you will have a lot of difference between the stiffness in the bone and the actual metal which you have put in. Patients will get high pains. And also when you want to put cemented stems, you got to be very accurate with your broaching, very less room for errors, not an issue with the cemented stems. And in spite of that, you may not be able to put a cemented stems in many of these patients, and again may have to fall back. Now, in some cases, when you have compromised patients, let's say rheumatoid or other patients on on immunosuppressive agents, you can even deliver antibiotics through your cement, which is again an advantage. Once you get stuck, let's say with infection or something else, periprosthetic fractures, when you want to take these stems out, think what stem do you really want to take out? A cemented one or an uncemented one? And again, you would really pray in this case that I hope my stems is a cemented version. And there are a whole lot of other things. Rehabilitation, as I mentioned before, thigh pains and all that, much less issues with the cemented stems. Look at the cost. Now, in developing countries, it's a huge issue. 3 times less cost with a cemented stem compared to an uncemented stem. Again, I believe in a scientific literature, we shouldn't talk about cost, but it is a huge issue. Look at the inventory you have to use for uncemented stems. Huge. With cemented, very less inventory. Now look at the results. This is where I think that matters. How many of our neck femur fractures will give us the results of 40-year survival? Well, we have results with the cemented stems. And even for non-fracture neck femur scenarios, we have survivalship of these stems almost 100%. And then also we look at survivorship from different areas. Again, very good survivors from different places, even for younger population. Now, if you look at across for THRs, for all the stems, cemented, hybrids, and uncemented, the revision rates are lowest for a cemented implants. And the Bible of where we normally go to is a Swedish one. Again, look at the cemented implants used there, huge in number compared to what we would do for uncemented. And I agree with my previous speakers that I think even if you take this as a 70 as your go mark, you can do a cemented stem for all these categories. But if you want to do an uncemented stem, I think you've got to choose a younger, more fitter population and who probably wants to do more activities than probably an older population. Yes, the complications, I have already discussed some of it. Sometimes we do have problem with cement, and it happens more and more with people who are now getting unused to doing cemented stems. I have met many American surgeons who have never done a cemented stem. Now, if we ask them to do ever a cemented stem, they are going to have problems using a cement. But I think if once you start using cement more and more, you'll probably realize it's a very friendly implant. And of course, you can have fractures even with cemented stems. Now, this is from the Cochrane review, looking at especially for hemiarthroplasty for intercapsular fracture neck of femurs, and look at across so minutes of research done into the going into Cochrane review. There is no evidence to suggest a bipolar versus unipolar, and cement comes out on top compared to this. So, this is the argument actually coming in from the Cochrane review. So no arguments really here. And these are some of my own cases. I don't think I can, bore you with all these cases for different areas. So different sizes of neck canals, different indications for a neck femur fracture, all can be taken care of bipolars. I don't use unipolars just because of the design issues. Really, even if I have a same style of a unipolar, I would be very happy. It's just the unipolars are designed very badly. That's the only reason I don't use them, and I go for bipolar. And some of them are self-centric, some of them are not. So they may look very funny on the X-rays, but they do function very well. So again, more issues. This is a case where you can leave it a bit of proud. This is the advantage of using cemented stem. You can put in more if you require. You can leave it proud if you require, just to balance your leg length. Again, more of a cases. Sometimes you see this is the case. Both sides uniblock hemiarthroplasty, but this is an uncemented version of a hemiarthroplasty. And what happens after a while? It broke. But again, revision has been done with a cemented stem because it's much easier. You've done even with a ETO, no issues. And again, I bring you back a study from China, an RCT looking at 1,125 hips. And the answer to that is cemented hemiarthroplasty achieves better hip function, low residual pain, less implanted complications, and less of, I would say that this is not really a longer operative times, but everywhere you see advantages going with a cemented stems. So what is the right answer, friends? So I think we should be non-biased rather than looking at a literature and looking what is my scenario I should worry about. What is my picture? Which hospital am I working in? What are our staff familiar with? Many of the OP staffs are not even familiar with how to make cements. So you've got to really think where you are working, and that is why we see a very much difference between our Indian scenarios and probably scenarios from abroad. Many of the abroad people have gone away from cement completely. So you need to know your own limitations, your own patient selections, and perhaps I think for above 70, probably cement is the way to answer. And I think I've heard from previous speakers, if it was a young patient, I would do that. 70 is 70. I think if they are 70, whether they are 70 young or 70 old, cement step in my case works for everybody. So in summary, I think if you look at fractured neck of femurs, there are design issues, insertion issues, rehabilitation, but all of these are issues with uncemented stem and not an issue with a cemented stem. Even if you are a person who wants to use an uncemented stem, please do keep cemented stem as a backup. You never know when you're exposed. Thank you.
Thank you, Rakesh, for putting a good case for cemented stems, whether they're 70-year young or 70-year-old. Now we'll hear from Dr. Min-Jae Lee about the cementless stem in the same scenario. And I'm sure that this will initiate a good discussion.
Okay, good evening. Thank you very much for the opportunity to present today's webinar, which is a wonderful collaboration between APAS and Indian Orthopedic Association. Certainly, neck of femur fractures are a devastating condition with 12-month mortality of 26 to 30%, even in the modern literature with new anesthetics techniques and orthopedic techniques. Starting uncemented, doing a presentation on uncemented stems and neck fracture patients is a difficult argument, especially after excellent presentation by Dr. Rakesh, but also multiple guidelines from the American Academy, UK, and Australia recommend the use of cemented femoral stems in neck and femur fractures. However, when looking into the literature, there is positive granular data, such as the use of total hip replacement data for when discussing all of neck and femur fractures patients, and studies often not differentiating outcome according to proximal femur morphology, implant design, and just using age as a cutoff for assuming all elderly patients have door C femurs. To start the discussion, I thought I'd present some disadvantages of using cementless stems in neck and femur fracture patients, which include greater surgical time, greater blood loss, and greater sudden death mortality rate associated with bone cement implant syndrome. This is a rare but catastrophic complication and can vary from hypoxia to cardiac arrest. The incidence of intraoperative mortality with bone cement implantation syndrome in this paper is quoted as 0.11% with the use of cemented stems. This is an early paper. By Dr. Parvizi, which demonstrated that sudden intraoperative death is strongly associated with the use of cemented stems, with no patient undergoing some uncemented arthroplasty being associated with intraoperative mortality in both fracture and non-fracture settings. Thus, the use of cemented stem is associated with significant risk. Now, some of the disadvantages of using uncemented stems in literature include shorter length of longevity of the implant, risk of intraoperative or early periprosthetic fracture, and higher perceived cost. Looking at our joint registry, data for patients undergoing total hip replacement for neck and femur fractures, there's no significant difference in rate of revision between cemented and uncemented group below the age of 70. However, greater than the age of 70 is associated with a higher risk of revision when cementless implants are used. It is postulated that this risk associated with intraoperative or early periprosthetic fracture has demonstrated in these two studies, looking at especially at use of cemented and cementless stems in hemiarthroplasty for neck and femur fractures. However, despite the early fracture risk, looking at functional outcome in the longer term, there was no difference in discharge disposition, Harris hip score, and ambulatory aid requirement in both these cohorts. Looking specifically at risk of periprosthetic fracture, this may be associated with cementless stems as its initial stability is dependent on prosthesis design and proximal femur morphology and coating material. Osseointegration occurs, unlike with cemented stems. Periprosthetic remodeling occurs during the entire implanted life of the femoral stem. Classical teaching with choice of stem is based on door classification, which is a ratio between the intrapatellar canal width 10 centimeters below the lesser trochanter divided by the canal width at the mid portion of the lesser trochanter. In type A patients, cementless stems may be used. Type B patient is dealer's choice, and type C patients, we would usually recommend cemented stems in the old literature. Another factor to consider is a type of stem used in fracture neck and femur patients. There are 6 types of uncemented stems classified by Kanuja et al. The most commonly used stems involve 3-point fixation, usually of the double wedge type, which involves 2 points near the metadiaphysis and 1 at the distal part of the stem. When cementless stems are used in door A patients, cementless implants are caught in the metadiaphysis with excessive impaction, causing fractures of the metadiaphyseal junction. In this case, it may be recommended to downsize the femur and then build up offset in length to avoid periprosthetic fracture. In door C patients, fractures are caused by excessive broaching or impaction of the stem in order to achieve mechanical stability. In this case, it may be better to increase the size of the implant and achieve better metadiaphyseal fit to achieve stability and sit a little proud rather than trying to impact all the way down, causing a calcar fracture. Another argument against cementless stems is higher perceived cost of implant when uncemented implants were first introduced. These stems came at a higher cost due to the greater degree of engineering required for its production. However, since its introduction, the cost of implants have significantly reduced. A UK study calculated purely implant costs associated with the use of cemented and uncemented stems, and it identified the Exeter and CPT stems as having the greatest cost per implant usage. This difference is greater when surgical and anesthesia time and implant costs are all considered with cementless implants, costing about $400 less than cemented implants. Therefore, when used judiciously, the use of cementless implants may be a cost-effective solution when managing patients with neck and femur fractures. Lastly, any arthroplasty talk cannot be complete without discussing risk of infection. The latest international consensus meeting recommendation was that there's no conclusive evidence that antibiotic-loaded cement is associated with reduction of risk of infection. When this is compared to cemented and uncemented arthroplasty, there is no difference in infection demonstrated in the Norwegian Arthroplasty Registrar. However, a meta-analysis from Koreans identified greater risk of deep infection with the use of non-antibiotic loaded cement in hip arthroplasty when compared to uncemented hip arthroplasty. There may be multiple reasons associated with this finding, including greater operative time associated with cement curing and greater loss of blood use, but greater loss of blood with the use of cemented stems, which are both correlated with higher risk of periprosthetic joint infection. In summary, there's a role for cementless stems in neck and femur fracture patients, and judicious use of surgical technique for various patients depending on implant time proximal morphology is required. There may be benefits of using cementless stems in neck and femur fractures in terms of cost and infection rate. Thank you very much.
Thanks, Min-Jae, for giving us a detail about the cementless stem. And we'll be discussing, and I'm sure that it's going to be a good discussion between what you spoke and Rakesh, cemented stems. Then next, I'll invite Dr. Anil Oommen to speak on post-operative care, perioperative care, and the role of bisphosphonates.
Is my screen visible?
Yes, Anil. Yes, Anil.
Thank you once again, Rajiv. Thank you, Rami. And thank you, the entire team, for inviting me for this talk. And my brief here as the last talk would be to talk about perioperative care in total hip arthroplasty for neck of femur and the role of bisphosphonates. And I would be going through a few case examples to illustrate the cause. And then we will, like we said, we can always have a discussion at the end. So this is a 75-year-old male, 6 months, who presented to us 6 months after a fall, diabetic mellitus on treatment with insulin and OHAs. And obviously his pre-op will have to be looked at in terms of optimization and also in terms of planning, general factors, control, anesthesia, and cardiac clearances as well. As mandatory, a templating was always done, even for a fractured neck of femur, because that's extremely important. Fixation, as Rakesh very eloquently put, would be considered a cemented type of fixation, especially in a dore, which would be kept as a backup as well. And would it be a hybrid fixation? And just to illustrate Rakesh's point, I think we did the hybrid fixation where we did the cemented femur with a good follow-up. And he went on to do well, ambulate well, and also post-op. What was essential was the sugar monitoring, mobilization, particularly attention to the wound, DVT prophylaxis. And in this particular age group, we need to pay particular attention to preventing chest and urinary tract infections. And that is what is of utmost importance, which all of you will agree. Templating is important, as illustrated in these few x-rays with a fractured neck of femur, because sometimes we tend to overlook the fact that the offset is not very much paid attention to. And this offset, what I'm referring to, is a horizontal offset, as you will see in these two cases where we required a higher offset on template, and that is what exactly was done to get the abductor tension back. And that is also an important consideration, especially in the pre-op evaluation of a fractured neck of femur. This, again, was an older gentleman who came to us with the diabetes OHA, and he, in fact, had an angioplasty on treatment. And that is probably one of the reasons where we thought we would avoid a cement. And this is, again, a post-op cementless THA, where we had done. We would probably do a cemented if the bone stock was inadequate. However, it tended to hold well. We kept the procedure short and we did a cementless THA. Now, this is a 65-year-old female who had a fall, fractured neck of femur. And just to illustrate an example, this was the intra-op X-ray. And to elaborate on the fact that sometimes we tend to do a unilateral hip X-ray, which does not give you the position even immediately post-op. It's always mandatory to do a pelvis X-ray, and that clearly showed us, this was a patient who showed us that this was a vertically placed cup, which eventually had to be revised. So intra-op, we have to pay attention to the position of the cup as well. Again, it's not an unusual situation where they have the delayed presentation, and the particular challenges with delayed presentations are the intra-op soft tissue releases, re-establishing the tension as well, as in this particular lady who underwent a routine uncemented total hip arthroplasty, dislocated, and did well after a close reduction. What the cause was, because aversion and all the other factors were right, but this seems to be falling in fact with the literature saying that dislocation rates are indeed a little bit of a concern in post-op fracture neck of femur undergoing total hip arthroplasty. Now, there's another subset of patients. This was a young lady who came to us with a pathological fracture neck of femur. Now, this planning requires a little different. The head is partly resolved. Obviously, we would plan for a biopsy. We would plan for further investigations and then proceed with what is called a cemented femur. In the histopathology, turned out as a GCT, and she required follow-up. Again, this was another gentleman who comes with multiple skeletal mets, diabetic melters, and other associated issues. Obviously, this would have to be done, but the pre-op evaluation includes planning. The hip surgery has to be done for mobilization, and the post-op follow-up care in conjunction with the other departments. Now, this is where the role of perioperative care comes into picture. And from the anesthesia perspective, it is the pre-op optimization that is absolutely important. Pre-op meaning there are planned care pathways that have been described, a cardiac workup. Anesthesia planning is absolutely essential. And more often than not in the geriatric age group, we talk about managing fluids and talking about monitoring. We talk about factors that are acceptable. Obviously, there are correctable cardiac conditions, but otherwise, we need to take these patients up without too much of a delay. Post-op, the importance has to be given, or attention has to be given to nursing, fluid balance, and obviously rehabilitation. Now, there have been pathways described like the enhanced recovery after surgery. And this takes into factor or consideration all these factors that are done at a little more faster or rapid pace in order to get these patients up and mobilized as soon as possible. Elaborating all our standard procedures, but done at a much more rapid pace. And this has been put out in literature, but again, they have the concerns of dislocation and infection as the complications that were put forward. And that is where they have said that the enhanced pathway does offer some benefit because the hospitalization is short, but again, the worries about rehabilitation and the following. Now, again, in our situation, what is not uncommon is a delayed presentation and the lack of mobilization for prolonged duration. Assessment becomes difficult. Risk explanation also becomes difficult, and that has to be explained in detail before we undertake these patients for surgery. Now, next part of my talk will go on to bisphosphonates, where we know that bisphosphonates promote bone formation by osteoclast inhibition after THA. And studies have shown that they are effective at increasing early bone ingrowth and also, in effect, reduce the need for revisions. But is that absolutely true? Now, evaluation and management, especially when you're talking about instituting bisphosphonates and more so in the elderly, we have to have certain basic markers that are evaluated, namely alkaline phosphatase, serum calcium and phosphorus, vitamin D levels, and preferably a beta cross-labs. Now, if the beta cross-labs before the start of therapy are low, then obviously we will not institute these bisphosphonates. And if the vitamin D levels are low, we have to get the vitamin D levels corrected before starting on bisphosphonate therapy. Teriparatide may be instituted in conjunction with the endocrinologist's input if the beta cross-lap levels are low. But just for our own awareness, the bisphosphonates that are available now are across 3 generations. And generally what is preferred now in the elderly age group are the parenteral or the zoledronate types, because the older age group is known to have multiple medications already. And this is a once yearly dose, which generates and facilitates better compliance. Remember, the bisphosphonates are given even in osteopenia with increased propensity for falls. And obvious contraindications for us to know are active cardiac disease with conduction defects or even heart failure. What are the adverse reactions that we have to be aware of? Patient can have even fever and myalgia due to cytokine releases, and which usually settles in 1 or 3 days. Now, what does the orthopedic literature say about bisphosphonates? Now, orthopedic surgeons in this latest few articles, they said could consider bisphosphonates for up to 1 year regardless of the patient's prior bone mineral density after discussion regarding the risks as already elaborated. Now, the role after this THA have also been put that they do increase or seem to increase the longevity of the implants, but is it so or is it absolutely warranted? Another article that's just been put out in the Arthroplasty itself, they say that the use of bisphosphonates is associated with slightly increased risk of intraoperative and postoperative complications, and thereby should be used judiciously. They compared two large subsets where approximately 20,000 who were bisphosphonates exposed versus the non-exposed ones, and they realized that aseptic loosening, osteolysis, periprosthetic fractures, and revisions were slightly more. So I think we should be guarded in the use of bisphosphonates, especially in the older age group. Again, there's another article put out there by Lee and group saying that they did not find neither beneficial nor negative effect of this agent in terms of stent fixation. However, it can be used. And they went on to evaluate two groups where approximately 100 in each group, and they decided that there was not a significant, or they analyzed that there was not a significant difference, so it is not going to be of much benefits. Remember that the bisphosphonates do suppress the osteoclasts, but somewhere down the line they do inhibit the osteoblasts as well. So for our perspective and in our institution, we tend to use this only after thorough endocrine evaluation, and in fact we hand it over to them to give take the way forward for these patients with osteoporosis. So in conclusion, in two parts of my talk, one was pre-op optimization would be including risk assessment. Intra-op would be assessing the soft tissue tension, offset, component position, and fixation would be of paramount importance. With intra-op and pre-op templating, post-op mobilization, associate risks and conditions management would be absolutely important. Management is essential. And use of bisphosphonates would be individual patient-based, and the endocrinologist input would be vital. Thank you for your attention.
Thank you so much, Anil. It's a point very well explained subject, and this completes all the 6 talks on this interesting topic. And I'm sure that it will initiate a lot of questions and discussion, which it deserves. Rami, I know that we are shooting the time by 5 minutes already. Can we have a short, brief discussion on this?
Yeah, definitely.
Okay? Right.
Look, yeah, I might just summarize some of those presentations, because Rakesh gave an excellent presentation, a very passionate view on cemented arthroplasty in the case of neck of femur. And he certainly gave the case for it, even though I will excuse him for some of the comments against cementless, which I don't quite agree with, but everyone's entitled to their own opinion. And then Min-Jae brought in a little bit of rationality to show perhaps there is a case for cementless total hip replacement and cementless use, particularly in the age groups between 50 to 70 or 75, depending on the region you come from and the reasons for that. But, suffice to know that if you look at the joint registry, Rakesh, you'd be happy to hear that the Exeter is by far and away the #1 stem used in the neck of femur fracture, followed by the CPT. So both cemented, and the Qurashi does come in, but probably at about 10% or 5 to 10% of cases that are used. So there is a case for cementless in select patients and with immediate mobilization and good outcomes. And then Anil showed us, obviously, that with some case presentations there, that it doesn't matter what approach or what implant you use. If you put your cup vertical, you're going to have a complication. So we've got to look at the basics, really, or stop people using total hip replacements. They're the ones who should be using DM or a bipolar to decrease the risk of instability. And then the question of biphosphonates, of course, I completely agree with Anil in that we should have combined admissions, as we do in our country, with a combined admission under the geriatricians, or the orthogeriatricians as we call them, and the orthopedic surgeon. And certainly the use of biphosphonates discriminately for those who have been diagnosed with osteoporosis with the engagement of an endocrinologist. I completely agree. So I think we should go to the panel now that we've had laid bare the evidence and the evidence base behind the selection of implants. If you were 65 and you have had an injury and you're still functioning as an orthopedic surgeon and active, and you want to return to the operating room, what are you going to ask your colleague to use in terms of approach and implant and articulating bearing for your subcapital displaced neck of femur fracture that had happened 6 hours ago? So why don't we go across the panel from top to bottom? Min-Jae, why don't you start off?
So I'm a relatively big Asian person, so I expect my bone quality should be okay because of the sheer weight that I put through it every day. At 65, I would like the approach that the surgeon uses the most commonly and the implant the surgeon that they're the most familiar with. If it is a cemented implant, it's not a huge problem because I don't smoke, I don't have any lung problems, cardiovascular issues. In terms of articulation, I'll really be keen for a ceramic on poly because I think there's plenty of literature that that's just as effective these days and avoids the whole problem with squeaking if something, is malaligned in terms of acetabulum. So that will be my preference if I was to have a neck and femur fracture 30 years down the track.
Uttam?
Sorry. For my opinion, in the 65-year, it's a cemented, tripolar, and posterior approach. This is my
Neil.
There's no.
Me, Rami?
Yes, Anil.
Like I said, I think like Min-Jae said, the approach would be what the surgeon is familiar with, but I think ceramic on polyethylene and fixation, definitely. I think assessment of bone stock at surgery is absolutely vital. Otherwise, I have no preferences.
Excellent. So,
I think Min-Jae basically summarized it the best. At 65, I'm hoping I'm sort of, making retirement plans. I'm already retired, so I'm not too worried about it. But the approach, whatever they do best and whatever they do regularly, because that gives me my safest option and that gives me my best chance of having adverse free outcome. Bearing, I go exactly the same. Ceramic on highly toxic polyethylene, it's got the widest margin of error and it's got the best results at 20 years. And I don't have to worry about fracture or squeaking, etc. Fixation, cemented, uncemented, whatever they do regularly, and as long as my bone quality is okay, I don't mind what fixation I get.
Dr. Vivek?
Same approach from the surgeon, ceramic on poly, preferably uncemented. I think that my bones are good, but keep cemented on the standby. Totally.
Rakesh?
Yeah, Rami, same as what Vivek said. I have no comorbidities, so I'm okay with whatever the surgeon actually chooses. But approach is up to him. If he asks me to choose something for him, then it is going to be an uncemmented stem, uncemmented cup, and a ceramic on body. And I would just like to add dual mobility.
I was going to wonder, because a group of orthopedic surgeons, we can't all agree on exactly the same thing, surely. There's got to be a little bit of individuality. So you would use a DM routinely?
Yeah, I do a lot of meditation, and I require to really sort of sit cross-legged for that.
Ajith?
Yeah, I was thinking of a hybrid really until I heard Dr. Min-Jae Lee say that cemented there is higher risk of infection. So I think I would again go for uncemented with dual mobility just to probably minimize the risk of dislocation rather than squatting. Thank you.
Eva?
If I am okay what I am now at 65, then I will tell the surgeon to go for a hemispherical cup, because I think dual mobility will be a better, more kill. Lateral approach and uncemented, because literature and the trend is uncemented stem. So this is what I will prefer at 65.
Kukuh, what would you have?
Okay, 98% of my colleagues do the posterior, so I go with posteriors, the total hip, and as a Muslim, I'm required to squat and cross leg, so I prefer dual mobility.
With a DM?
Uncemented, yes, uncemented.
Okay. And I think I'm in that camp as well. I'd be very comfortable with whatever approach the surgeon actually utilizes on a regular basis for his joint arthroplasty. if I had a preference and I was asked, but I wouldn't pertain to tell the surgeon what to do. It's whatever's good in his hands, but I would go with cementless implant and with a ceramic on ceramic at the age of 65. That would be my selection, even in a neck of femur fracture. Rajiv, over to you, and then we can wrap it up after that.
Right. Rami, I would prefer the same ceramic on ceramic articulation because 65 will remain quite young, and a cementless option is the best option. Dual mobility, I would probably not be in favor of dual mobility only. My feeling is that a good orientation, a well-balanced joint is okay for all the activities. Before we wrap up, Rami, can I ask one very important question from the panel? That how many of us are sending the implant, the removed femoral head for the histopathological examination? Do you send it routinely for the histopath examination, suspecting that there could be a tumor condition which you are missing?
So I would say, no, I don't send routinely, but we saw a couple of cases of giant cell tumor there. So if you have concerns that it was a non-traumatic injury, then yes, definitely. But in the majority of cases that present, they are traumatic, routine, and no, that would not be sent away. You may even donate some of those heads if you have a bone banking facility, but otherwise they'd end up in the bin.
Yeah, so with Rami, we don't routinely do the histo, but we send for the tissue bank.
Right. Yeah. We in our place are sending probably most of the patients who are above 70 for the histopath, suspecting that you may be missing out something on X-rays because most of these patients are coming in the emergency. But I think that remains a very important point. Now, I think, Rami, it has been a very interesting discussion and excellent, very eloquent disposition of the lectures in a very, very different situations. I think this has completed the whole scenario about the fracture neck of the femur from fixation to the cemented and cementless options. Thank you so much, all the speakers. Thank you so much, Rami, for giving this opportunity and having an association with IOA on this webinar. You'd like to say some last words?
Yes, what I'd like to say is actually for the 6 presenters who actually took the time, and I know how long it takes to prepare a presentation, so truly grateful for them for taking the time and doing that, and for joining us for this first combined session between IOA and APAS. So grateful to you all. Thank you very much.
Thank you so much to all the panelists as well, who could find out time in their busy time of the afternoon in India. Thank you so much. Thank you all.
See you in Cebu.
Thank you.
Thank you.
Thanks, everybody.
We'll be stopping the recording
Thank you.
now.
Thank you, sir.
Okay. See you next month in
thank you,
Cebu.
sir.
Recording stopped.
Yeah, so now the recording is stopped.
Very good.
Thank you so much, Rami.
Well done.
And thank you, everyone. Yeah.
Thanks, everyone. Enjoy dinner.
Yes, it's too early for us here. It's just 5:15.
I'm starving.
So
I got home late, and my dinner's still up there for the last hour and a half.
Go have dinner.
There you go. Thank you, gentlemen. Thank you, Rami. Thanks, Rajiv.
All right. Thanks, everybody.
thank you so much, everyone. Bye. Bye.
Thanks, Rajiv. We'll talk to you
Thanks,
later.
Rajiv.
Thanks, everyone.
Thank you.
Thanks,
Bye-bye.
Ajith. Thanks, buddy.
Thank you.
Thanks.
Bye.
Thank you.
Thank you.
Thanks.
Thank you, sir. Thank you. Thanks a lot.
See you, Uttam.
Thanks so much, Deba.
Yeah. See you.
Thank you.
There are three ways in which AI is going to change your job forever. AI tools can
that how many of us are sending the implant, the removed different situations? I think this has.
Thank you, gentlemen. Thank you, Rami. Thanks, Raji.
Case examples like one patient with polio around 50.